So I'll go through the slides. So my name's Charlie Murray. I'm a consultant gastroenterologist. I'm clinical director for gastroenterology at the Royal Free Hospital. I also work at UCLH Hospital in London, both in London. And so I do lots of inflammatory bowel disease and general gastroenterology. But as you know, I'm sure, with Chris Denton, we have a national centre for scleroderma. So I tend to see lots of patients with scleroderma. And you'll also know that, therefore, because most units have relatively few patients with the disease, that we tend to see much more. So we've got a lot of experience, but we're obviously finding our way and trying to make things better over time. And I'll talk about some of the things we're doing. Now, again, if this was a big talk and we were here for half an hour, we go through all of these things in detail. But this is just basically what I have on my slides. You can interrupt me at any time. Pathophysiology just means talking about what causes problems in the gut. And again, you'll find out from me talking that we're not entirely sure about that. Symptoms you'll all be very aware of, the patients among you. Established therapies, things we use all the time. Putative, meaning things that we think are going to work well, but we don't necessarily have a good evidence base for, but that's evolving because we're using them more and more. Novel therapies for treating gut problems, some of which are undergoing trial at the moment. And we do have these pathways, which Chris was alluding to earlier in general about the UK Scleroderma Study Group. So that's a group of, for the GI pathways led by me, Chris does others, Aaron Herrick does others, looking at particular symptom bundles, if you like, within scleroderma and how they might be treated. The idea being that if you get enough gastroenterologists, rheumatologists, surgeons, radiologists, patient groups, patient advocates in the same room, we can come up with some guidance for those people that don't see a lot of scleroderma, and that's what we've done in that group. Okay? So, again, this is no news to many of you. Gut involvement scleroderma, despite all the other horrible things that can happen, if you like, can be one of the worst things to deal with because it can really affect day-to-day life to a huge degree. Up to 90%, and 90% really being the esophageal symptoms, 90% or thereabouts of scleroderma patients have some, and sometimes terrible upper gut symptoms of reflux, regurgitation, difficulty swallowing. But any site of the gut can be affected. It can affect you really from your mouth to your bottom. It's not always symptomatic, which is very interesting to us because it means that actually if we go looking, we find some abnormalities in patients that have no symptoms at all, which maybe suggests that one of the problems that I have is that by the time I see people with severe symptoms, the damage has already been done to the gut, and maybe I should be intervening a lot earlier. But of course, it's difficult to ethically run studies where you start giving potentially toxic drugs to people who are completely well, based on the premise they may develop problems in the future. So it's not an easy way around that at the moment. It can occur at any time, and it's not limited to either, sorry to say the same word twice, limited or diffuse systemic sclerosis. So both of those conditions have problems. There is a subset of people with diffuse disease that have problems very quickly and very aggressively early on, but that tends to be associated with things like pulmonary and cardiac disease as well. So there are different groups of patients with different symptoms that occur at different times, but anyone with either type of disease can develop problems. It certainly increases morbidity. That means illness, symptoms, sickness, quality of life. Mortality, just to be somewhat reassuring, gut disease and scleroderma in itself isn't often the cause of a shortening of lifespan by any stretch, really. If it's associated with other conditions, it can be, but it's actually probably one of the biggest morbidity causes. So sometimes you'll ask people with terrible pulmonary fibrosis, whose breathing is very difficult, what's the worst thing in your life? And the worst thing isn't carrying the oxygen or getting around. The worst thing is that I can't go anywhere because I'm incontinent 24 hours a day, you know. So it's a huge cause of morbidity and one which we need to work harder on. And what can it do? It can affect the esophagus. That's the upper left here is someone's esophagus is very sore and ulcerated. Just to reassure anyone who's had an endoscopy by a gastroenterologist who says there's nothing wrong, it doesn't look bad, you can have appalling reflux and regurgitation and still not have significant signs in your gullet. So one doesn't necessarily follow the other. Conversely, you may have relatively little symptoms, and when we look, actually there's lots of damage, most of it acute, so we can deal with it and suppress acid. Some of it more long-lasting, for example, when the coating of the gullet changes to more like a stomach lining, and that's called Barrett's esophagus. But for this reason, certainly when people have got symptoms and they come to me, I always try and make sure that at least one endoscopy has been done, because it's very useful to know right at the start of that disorder what we're dealing with, and then only then intervene thereafter if one needs to. This funny cloudy photo is an endoanal ultrasound scan, which some of you may have had. This is when you're investigating incontinence. But that's looking at two things really: internal muscle, which is this white thing here, and the external muscle around the outside. And the reason I've left that on there is just, when we talk about pathophysiology, what causes problems. The reason scleroderma is so cruel to the gut is it preferentially affects something called smooth muscle. Now, smooth muscle is a type of muscle within your body you don't have conscious control on, so you can't think it better, if you like. And smooth muscle is supplied by what we call the autonomic nervous system, so they're automatic responses. So, for example, the anal canal is a good example of that. You have an internal muscle, internal sphincter, and an external muscle. The external muscle is a bit like your bicep. It's the one that you squeeze when you're desperate to go and you can't hold on. The external muscle can be a bit thin, but tends to be intact in scleroderma. The internal muscle you don't have conscious control over, but it should be doing its thing to keep continence there by having a pressure that's associated with holding everything in. But scleroderma, in fact, is cruel in that sense, in that it attacks that muscle preferentially and it causes it to, what we call atrophy, to get less thick. And it's there that we see the problems, and that's that causes the leakage and the difficulty holding on and the incontinence problems initially. So that means a lot of the things we may think we're doing to help incontinence might not be effective in this condition, and I'll talk about that later. Now, in terms of what's happening, I won't spend too long going through some of these big words on here. All of our knowledge about what the main causes of these symptoms are based on getting tissue from patients and then when we're taking them out, and then doing physiological studies when they're in. So we know what goes wrong, but why it goes wrong is less clear. We know that there's damage to vessels because we see bleeding, we see lack of blood supply in some scleroderma patients. We know the nerves aren't working well because if you look on an electron microscope, they're damaged in scleroderma, and there are 100 million nerve cells in your gut. So if you imagine function is all to do with all of those nerves talking to each other, you don't have to damage many of the nerves for the function to be, very much damaged itself. But there are lots of things going on. The myopathy is for a particular group of patients. Usually we think myopathy meaning damage to muscles, who present with an overlap with myositis. So if there's inflammation in the muscles, this is probably a different patient group that are having different problems with their gut. And intriguingly, I'll talk about that later, in terms of intervention, this is one group where we're seeing if you have muscle inflammation, genuinely with enzyme rise in the blood and demonstrable evidence on MRI, for example, in your skeletal muscles, if you have myopathy of the smooth muscle in the gut as well, that sometimes does respond to immunosuppression, which we haven't seen for a lot of other patients. And you say, well, why that's interesting, because it doesn't help me, but what it tells us and makes us think about all the time is that not everyone is going to be the same with this condition, and that we shouldn't just be plugging on with the old treatments, because some people should be treated differently. Now, I don't suppose any of that is any news to any patient with scleroderma, and I'm sure some of you have all of them. Some of you have some of them. We know from our studies, which isn't necessarily real life, but the studies we've done, that 90% will have esophageal symptoms. That's dysphagia, difficulty swallowing, reflux. The minority have malabsorption and weight loss. It may not seem it for the people that have severe problems. And diarrhea and constipation, again, cruelly, both conditions can occur, so you can swing from one to the other. Incontinence, you'll see on the next slide, is reported as being very low, and I think that's because it's underreported, not because it's a rare event. I think people just, when they're suffering with other problems like their lung disease or their terribly painful ulcers, tend not to mention that in their window of opportunity with their busy consultant in the clinic while he's looking at the clock trying to move them on. Of course, no one would ever do that. But it's a knowing laugh from the audience. But again, I think it's underreported. Pseudo-obstruction, the pseudo means false, is when, and again, some of you may have had this, when the bowel distends and looks like someone's actually obstructed the bowel. So it looks, for all intents and purposes, like the abdomen is distended and the bowel is distended because it's obstructed. but it's not. It's just not working, and it's just started to dilate, and it's not moving. It can be very difficult to manage. And the top symptom on the top left is almost ubiquitous. The early satiety, the getting full quickly and feeling bloated and uncomfortable. And just from an American study, but also our own with Nora Thur and Chris Denton, these are very similar. So again, not so high of dysphagia and heartburn, but heartburn goes up to over 70% in this. I think this is too low. But if you think about, but this is just from one study in the States, but if you think about all of that, you can see why I keep saying that morbidity-wise, illness, quality of life-wise, if that's your Scleroderma cohort, and everyone has gut symptoms, then everyone's suffering, basically, and is not well controlled. So I'll say established therapies, and I know full well that for many of you these don't work, so maybe established is the wrong words, but certain drugs that we don't use often, sorry, we do use often, and we think of the mainstay, but actually all we end up doing is increasing doses of them and changing them around. That's not because we're cruel and boring and don't think outside the box, if you like. It's because we really do have limited tools available. So we know, so far, the best acid suppression is a proton pump inhibitor. It's something like omeprazole, lansoprazole, pantoprazole, rabiprazole, those drugs. They are the best at suppressing acid. The reason they're so disappointing in some patients with scleroderma is you probably don't have much acid left, but it's done nothing about the non-acid stomach contents, the lower esophageal muscle being weak, the fact that your gullet in the lower two-thirds doesn't clear anything from the gullet, and then about 30% of patients, the stomach doesn't empty either. So those drugs will do nothing about that. They'll just take the pH up on the acid down, if you like. Prokinetics are drugs, the term means that they improve the kinesis, so they improve the emptying of the stomach and try and get things through the bowel. This group of drugs, and I'll go through them, are difficult because one by one, the Medicines Agency keep taking them away from us, basically, and saying they're all unsafe. So we have always used domperidone. Some of you may still be on it. And we still use it, you're still allowed to use it, but there is a big warning about potential effects on cardiac arrhythmia. So that was available over-the-counter domperidone as Motilium for years, but you'll see it's disappeared now. And that happened within the last year or so. Metoclopramide, which we've used for decades for sickness in hospital use, is now meant to be used intermittently and sparingly, but we do use it long-term in some people that need it because it makes such a difference at emptying the stomach. And many of you may have been on erythromycin, which is an antibiotic. And again, the fact that we have to use erythromycin is really a failure of our drug development, because erythromycin we only use because it has the same structure, well, a very similar structure to something called motilin, which is a protein your gut makes to make your gut move. So you're making it all the time, and this is trying to give a big heap of that to make the gut move better. The problem is that erythromycin in every study we've done usually works well, might not work for some of you, but usually works well initially, but we do know that all the receptors become saturated quite quickly, and if you use it continually, the effect definitely goes away. And that's why the drug development has been so poor, because every lab model which isn't an antibiotic of that motilin receptor stimulator has had the same problem so far. So we're still working on these actually, and there are a few drug trials around, but not in scleroderma at the moment. And cyclic antibiotics we're using a lot. I have to be very honest with you, it's all done experientially. We know that small bowel bacterial overgrowth in scleroderma is a huge problem. Why is it a huge problem? Well, the small bowel is meant to be relatively sterile. Your colon has trillions and trillions of bacteria in, which are probably related to health, but those, as you go up the small bowel, get less and less in health. And that's the status quo, that's how it should be. But if your small bowel is not clearing food content and liquid content through constantly, you will overgrow those bacteria you're consuming all the time that we're all exposed to. The wrong bacteria, I know it sounds like a yogurt advert, but if the wrong bacteria gets in your gut and they overgrow, they're going to cause distension, gas, pouring liquid from the gut, trying to get rid of it, and those awful symptoms of diarrhea and floating stool and occasionally weight loss that can occur and distension. The problem is that until now we've been using, in fact currently we're still using absorbed normal systemic antibiotics. So that can lead to obviously resistance to the bug, so it doesn't work anymore, and obviously the attendant problems of being on lots of antibiotics over time. So there are non-absorbable antibiotics, but currently they're really expensive. And embarrassingly, even my hospital won't let me prescribe the main one, which in mainland Europe is an over-the-counter remedy for travellers' diarrhea. So I should just go over and buy a stock load and bring it back to the clinic. But I'll talk about that. That's rifaximin. That's really disappointing. So immunosuppression, again, for those of you who have other conditions, so those of you who had cyclophosphamide, methotrexate, mycophenolate, etc., for other problems in scleroderma, none of the studies have shown an improvement in gut disease. And maybe that's because we're too late. Maybe we should be doing it early. But again, I come back to what I said at the beginning. It's very difficult to do studies on well patients that have no symptoms. So personally, if I had scleroderma and I had no gut symptoms and no reason to have cyclophosphamide, I wouldn't be signing up for a cyclophosphamide study. I don't think many people would. And I don't think we can ethically justify that. So maybe by the time we get the gut disease, we haven't done enough intervention, and it's almost too late, if you like. I did mention this earlier, didn't I, that this myositis group, we've got a whole cohort of Royal Free of about 10 patients now that have had the medication, and when we've scored their gut symptoms, they do transiently improve over time. So there's obviously an improvement in muscle function in this one particular group, but it doesn't seem to work for those that don't have myositis. Again, on here, I've mentioned these. Prucalopride is not really new anymore, actually. I keep putting it up there as new, but it's otherwise known as Resolor. It's a 5-HT4 agonist. In English, that means it stimulates one of the serotonin receptors in the gut, predominantly the colon, and makes it move better, therefore only useful for people with constipation, and can spectacularly backfire if you also have incontinence, because, of course, if your colon's moving quicker, it's very difficult to hold on to things. Rifaximin is the non-absorbable antibiotic I was talking about, which is the traveller's diarrhea one as well. It's not absorbed into the system, so intuitively it's a really good medication to use for bacterial overgrowth because you're not getting any effects outside the gut. Very expensive, not signed off by NICE for treatment of bacterial overgrowth at the moment, so that's something we need to work on. It's been very hard getting that through. And some may have this condition, gastric antral vascular ectasia, which is vessels in the gut, a bit like the telangiectasia on the face. You get them in the gut. It's my little sales marketing pitch, if you like. We have a study going on for this at the moment because there are a few patients, and again, varies massively in studies from 5% of scleroderma patients to 30% of scleroderma patients have that condition. And some of those will be anemic, and some of them will be significantly anemic, requiring blood and or iron transfusions. So typically what we've done is we've done things where we burn the vessels away. It's called argon plasma coagulation. Can be effective, usually requires multiple endoscopies. Let's face it, not very nice to come back from multiple endoscopies and have a plasma gas burn your stomach lining away. It's not a nice thing to have done, but it does work, but it uses multiple problems. And we have other modalities we've done like laser and banding. But we've now got this other technique called radiofrequency ablation. Now, I know in the other room my slides died, so I don't know whether you'll see them. They never died again. So you have to wait a while. I'm sorry about that. So this is the condition. I don't know if anyone in the room has had it, but it's when you have the same things you've got on potentially your tongue or your skin in your stomach. And these bleed because the stomach moves, so the vessels move, and the vessels bleed. And actually we're using a technique where we put a paddle and put a high frequency through it, and it ablates all the vessels. And unfortunately, that is the before picture, and all the other pictures have died apart from, I think, the after picture, which is one of our first successes. Now, if anyone does have severe GAVE, I never know who you're talking to, but if you do, and you're having iron transfusions and blood transfusions and it's not getting better, this study is going on at UCLH at the moment between myself and a guy called Dr. Hadri. So it's a technique that's established anyway for other conditions. The reason we hadn't used it ever in scleroderma until now is you used to have to do it by putting a big instrument on the top of the scope. So if you think that having an endoscopy is bad enough, you imagine putting something twice the size on the end and trying to get that down. Totally impossible. But it now goes through the working channel, so there's no increase in diameter of the scope. It comes out as a paddle through the scope and then opens up like a sail. So that's a technique that's available now in a study. And it's for people with GAVE and scleroderma that have iron and or blood transfusion requirements, even if they're 1 or 2. He's going to roll me up, isn't he? I can see it. So in terms of other things, for incontinence, we've been working on stimulating nerves. Some of you may have had sacral nerve stimulators where you put wires into the sacrum, have an operation to implant a stimulator below the skin. So I was at St Mark's for sacral nerve stimulation back in 2002 when Nick Kennefick did those original studies looking at small numbers of scleroderma patients with sacral nerve stimulators and incontinence, and reported good responses. We know from experience now, and you know, there's not more than around 50 patients UK-wise at least that have had the implants with scleroderma. There's more that have had incontinence. There you go, you've had it. About 50% of patients have some response. Of those 50%, not all of them maintain response. And my experience personally has been quite disappointing. So I think if 50% of people are going to respond and it works, then it's often worth trying, but it shouldn't be offered as a panacea. I'm sure surgeons, I hope they didn't anyway, but surgeons shouldn't be offering this as a cure, this sacral nerve stimulation, but it can be very useful, something we still use now and then. This is posterior tibial nerve stimulation, which as you can see makes you very happy and an avid reader. But the idea is that you have interesting concepts. Sacral nerve stimulation is putting wires directly into your sacrum and then stimulating them on the table to see whether they're affecting muscle contraction in the anal canal. But actually turning the stimulator on, if you look physiological, improves gut blood flow, improves in the initial studies, I know it doesn't work for everyone, improves tone and improves sensation in the initial studies. So if you're getting that from stimulating the sacral nerve, the idea here is, well, why don't you look at something that we know has a reflex arc. So if you stimulate the posterior tibial nerve, as evidenced here by the needle that's placed in there, without actually inserting anything to the body, you get a reflex arc, oddly enough, going back through your sacrum. So you're actually doing the same sort of thing. Now, this hasn't been cleared by NICE for fecal incontinence for all comers, although we're pushing for it for scleroderma. The initial study, which isn't published yet, does show some very good effects. But again, not in all patients. So initially, we had much more than 50% responding, but over time, I'm not sure how many will. But if we could roll this out a bit more, I do think it's a good choice for people on the grounds that it's minimally invasive. Although there's an electrode involved, it doesn't hurt particularly. You can do it at home, we hope, in the long term. And in the study, it was an hour a week. So it's still an hour. It's a bit of a pain, but it is 1 hour a week, and people had much better scores in terms of incontinence. But that's, as you can see, terribly small numbers. The scientists amongst you will get me up on this, but they were with small numbers. But the sham procedure was, we hope they didn't know which one they were having at the time. It was just a stimulation, so there was a buzz on the side of the leg when they had the procedure. There were definite differences. So there is something in this, and something we want to get going a bit more, but the difficulty is funding, because unless you have nice accredited funding, or government level accredited funding, which we don't have, then units have to pay out for it themselves. So UCLH in London are still doing this. We're all free. We're trying to put a business case together to get this as a technique we can offer more frequently. And just so you know, these consensus pathways, we looked at symptom groupings, so all of which will look very obvious to you, on the grounds that we would look at problems that affected everyone and how one might deal with them. And although there's a lot of words within the document, you can look it up online. I think it's freely available. And you don't need to read this, but they're all the same. They're all looking for the general practitioners about what one would do in certain situations. They're all very systematically based. And I was meant to talk about nutrition. One of the main problems with nutrition it seems to be a UK problem, actually, because I've worked with colleagues in the States, and they're much more on to getting onto things quickly. We're very bad, we as a profession, by the way, I mean, not the patient groups, the doctors, at noticing when people are, if you like, falling off a cliff in terms of nutrition. So nutritional failure in scleroderma has multiple causes. You can't chew if your mouth is bad, you can't swallow if your esophagus is bad or you don't want to. If your stomach is empty and you're vomiting, you won't eat half the day anyway. If your small bowel doesn't work properly, you can't absorb, and if you eat and you get massively distended, you can't face that anyway. And if every time you eat you're incontinent, then you're in food avoidance. So there's so many reasons. And often we'll see people losing weight, but the intervention comes far too late down the line. So one of the problems of all of this is that with progressive weight loss and nutrition in scleroderma, you do need to act in a timely way, and you do need to think of there isn't one size that fits all here. So if you come and your problem with nutrition is all because you can't chew, swallow, or get anything down the gullet, but actually you don't get much in the way of diarrhea and things, then we can test to see whether or not by putting a tube from the nose into the small bowel, whether you would tolerate that. And if you did, we could give you temporarily, or in some cases permanently, a tube that feeds food into the small bowel to get the calories back in, to get the weight back on. That is not going to work for someone who gets hugely distended, terrible diarrhea, bacterial overgrowth and pseudo-obstruction. So it would be an invasive procedure that would be unhelpful. And someone from the last group said, actually, I think was telling me off because I didn't mention intravenous nutrition, mainly because I ran out of time. Intravenous nutrition scares us all because it seems like such an irreversible process, and it involves a line that goes into a vein, but it can be an absolute turnaround in terms of quality of life, in terms of putting weight on, feeling better, being able to avoid, if you like, some of the things that cause problems with the gut. So it should never be seen as anything but something that just helps. It can be really helpful. So although parenteral nutrition is something that we don't use often, we do use it, and I think, my impression, UK historically has not used it enough. I think when people are getting to a point where there's nutritional failure, it can be a real winner in terms of symptom control and allow you to concentrate on everything else.